Hello, everyone. Thanks for joining us. Just hold on a few more seconds. We're having everybody's computers load, and as soon as we get a few more people on the call, we will start the webinar. Thanks in advance for holding. Hello, everyone. We'll start in just a few moments. We're just waiting for a few more people to join the call. I can see some spinning wheels and people trying to connect. So thank you in advance for holding. Good afternoon, and thank you for joining us today. We have a few housekeeping items before we start today's program. I'm Andrea Jensen. I'm the education specialist for Allergy and Asthma Network, and I'm also a certified asthma educator. All participants will be on mute for today's webinar. We are recording this, so have no fear. If we go through information and you want to go back and review that, we are recording it. We will post it on our website within a few days. You can find any of our recorded webinars and any upcoming webinars on our website at allergyasthmanetwork.org. Scroll down to the bottom of the page and you can find any of our recorded webinars and upcoming webinars. This webinar will be 1 hour and we will allow time for questions. We'll take those questions at the end of the webinar, but you can put your questions in the Q&A tab at any time. The Q&A tab is at the bottom of your screen on the left. People have a habit of putting their questions in the chat, but sometimes those get missed. So please use the Q&A tab and we will get to those at the end of the program. We do offer CEUs for this webinar. This webinar is part of our webinar series, Advances in Allergy and Asthma, in partnership with the American College of Allergy, Asthma, and Immunology. Allergy and Asthma Network offers CNE for nurses and CRCEs for respiratory therapists. The American College of Allergy, Asthma, and Immunology offers CMEs. And if you are a member of the college, there is no fee to be able to get the CE for this program. You'll receive an email within a few days after the webinar. We will have all the resources from the webinar and links to access continuing education credits. You will also have a link to be able to get your certificate of attendance. So asthma and COPD can have many overlapping symptoms and treatments. How do you tell the difference? Dr. Marshall will help us learn about that today. Allergy and Asthma Network is a grassroots organization that was started over 35 years ago by a mom who knew that other mothers like her needed resources and support. Our mission is to end the needless death and suffering due to allergies, asthma, and related conditions through outreach, education, advocacy, and research. Today, it's my pleasure to introduce our speaker, Dr. Gailen Marshall. Dr. Marshall, MD, PhD, is the R. Fraser Triplett Senior MD Chair of Allergy and Immunology, Professor of Medicine, Pediatrics, Pathology, and Population Health Science, Executive Director of the Mississippi Clinical Research and Trials Center, Medical Director of the UMMC Clinical Research Support Program, Vice Chair for Research in the Department of Medicine, Director of the Division of Allergy, Asthma, and Clinical Immunology, Chief Laboratory of Behavioral Immunology Research at the University of Mississippi Medical Center in Jackson. Dr. Marshall received his PhD in immunology and his MD from the University of Texas Medical Branch, in Galveston, did internal medicine training at the University of Iowa, and completed his internal medicine residency, chief residency, and allergy immunology fellowship at the University of Tennessee in Memphis. He is an active clinician, educator, and research investigator. His main research interests focus on the clinical effects and underlying mechanisms of psychological stress in the context of genomics, environmental factors, and lifestyle choices, on dysfunctional immune responses involving the allergic rhinitis, asthma, COVID, etc. He also studies the immune modulatory effects of new therapeutic agents for allergy and asthma, and the effectiveness of an integrative approach to allergy and asthma care using botanicals and natural products. He has published over 250 peer-reviewed articles, reviews, and book chapters. He's an active speaker in regional, national, and international venues. He has extensive editorial experience and recently completed his 16-year term as editor-in-chief of the Annals of Allergy, Asthma, and Immunology, which is quite a feat. Thank you for your work in that area. He is president-elect of the American College of Allergy, Asthma, and Immunology, and will start his term as president November of 2023. And for any of you that wish to attend that conference, the annual conference will be in Anaheim, California, right near a certain amusement park that has a mouse as its mascot. Dr. Marshall is married and has 3 children and 5 grandchildren. He enjoys amateur radio, astrophotography, and fly fishing, and is an active church and community activities. Whew, thank you, Dr. Marshall. So impressive. The time is yours.
Thank you, Andrea. And I also get sleep every once in a while as well. Thanks everybody for joining. The video is not working, so you just have a picture of the slides, which trust me is better anyway. I just got back from a meeting in Germany and I'm suffering from jet lag, and I look my age. So I think you'll enjoy the slides very much more. We're going to talk about obstructive lung disease today. And actually, if there's a subtitle of this, this is obstructive lung disease for the asthma providers. I grew up in internal medicine training, decided to be an allergist relatively late in my training, thought I was going to be a pulmonologist for a while. And so an awful lot of COPD and interstitial lung disease. Asthma was sort of trivialized as I began to do this for a living. I recognize that it certainly wasn't trivial at all, but now what's happening is full circle again, is the obstructive lung disease spectrum is amenable to many of the therapies as one used for another. So in the next 35 minutes or so, my hope is to get you sort of used to or comfortable with some of the vernacular, some of the terminology, similarities and distinctions, specifically for the purpose of better diagnosis, better predictors of prognosis for our patients, and more effective therapeutic development. And if I do that, then I've been very successful at what I'm trying to do today. So if you think of obstructive lung disease, it's really, you define it as opposed to interstitial lung disease as decreased airflow due to diminished airway patency. It's typically perceived as exhalational dyspnea. And the interesting reason for that is, remember that in the respiratory cycle, the inhalation, exhalation, inhalation is an active process. The intercostals constrict, the diaphragm constricts, the intrathoracic pressure increases, and air flows in. But exhalation in the normal individual is a passive process. All of that is just relaxed, and the air is squeezed out like squeezing toothpaste out of a tube. As the airway diameter diminishes, there's an increase of effort to get air in and out. But the increased effort on top of the already active inhalational process is, at least early on, not perceived as a problem. But now, because of the delay in the exhalation, because of the decreased diameter, the body now begins to perform work to squeeze the air out, if you will, and that's what the individual perceives as dyspnea, typically relate to exhalation. Certainly, as airway trapping occurs, as the illness progresses, be it asthma or COPD or some combination of that, that can change and become more of a pan cycle. But early on, it's exhalational. There are multiple different causes. Acutely, of course, things like foreign body, an acute occlusion of the airway, either partial or complete. Infections, typically bronchitis type things, less so in pneumonia. Though there certainly can be dyspnea pneumonia, but there's more likely to see this in airway infections. And then systemic mast cell activity that affects the lungs in a condition that we call anaphylaxis. Asthma, COPD that we're going to talk about today, and then other conditions such as cystic fibrosis, and even certain types of tumors, either those that might be endobronchial and cause a fixed mechanical obstruction, or those that are in the lung parenchyma or surrounding tissues that externally compress the airway, and the end result is still the same. There's decreased patency. So obstructive lung disease is decreased airway patency. I'm old enough now, coming up on my 40th anniversary of graduation from medical school. And what I remember very distinctly in medical school and even in residency is the discussion about asthma and COPD in the context of it being silos. Asthma was one disease, COPD was another disease, and there wasn't really much in common with them. Even though historically we recognize that they were obstructive lung disease, there was big differences in risk factors. Asthma was considered a disease of children and young adults primarily, and was considered an allergic problem. COPD was smokers. People smoked, they were going to get COPD. There was not a real consideration of the overlap that could occur. Clinical manifestations, asthma is reversible, COPD is irreversible. So if it's reversible, it's asthma. If it's irreversible, it's COPD. As a result of therapeutic choices, asthma, we fairly early on, even during my residency, became very clear that asthma was an inflammatory disease with bronchospasm, not just a bronchospastic disease. So treating the underlying inflammation as a controller, if you will, within the resulting reliever when necessary for rescue, as opposed to COPD, where the main process, at least until later in disease, was airway patency, trying to maintain it as best you can. So bronchodilators were the primary therapy in COPD. And then the long-term outcomes, very few people, relatively speaking, died from asthma, whereas it was considered, COPD was considered a fatal disease, that if you have it long enough, 100% of the people will die. Now, what came to pass is a further study revealed that some asthma either had or developed irreversibility. We used to call it airway remodeling. It's still called that to some degree. And COPD can have a reversible component, which is usually more pronounced early to mid disease than it is in very advanced disease. But what then developed was the idea that this, instead of being a silo, would actually be a spectrum, and that there was overlap that was possible. When you classified asthma versus COPD, commonly, again, we knew that both of them were obstructive lung diseases, both of them had bronchospasm associated with them, and both of them had inflammation. But there was distinctions that were made historically and classically. The nature of the inflammation in asthma was considered eosinophilic. I'm old enough to remember when the eosinophil was called an asthma cell, because that's what people associated with it. In contrast, COPD, with the sputum that was produced, if anyone ever stained the sputum, it was full of neutrophils. So it's considered to be a neutrophilic disease as opposed to asthma as an eosinophilic disease. There was the issue of, in bronchospasm, whether the bronchospasm was from an adrenergic deficiency or cholinergic excess, remembering that the airway, natural tone of the airway in the healthy individual is under cholinergic control, but in asthma and to a degree in COPD, it is considered that they have an adrenergic deficiency, and classically in COPD, it was considered they had a cholinergic excess. So anticholinergics were used in COPD and beta agonists were used in asthma. We now know, of course, again, that there's a spectrum of that as opposed to the silos, and that obstruction was largely reversible in asthma and largely irreversible in COPD. And while that's generally true, again, there's a middle ground in that has never really been said before. I think if you get nothing else out of today, you're going to hear me refer to over and over again of what that middle ground is, that it exists. I can't tell you what it is because I don't know what it is, but that it does exist, and that it exists along a spectrum. And that has importance for not only prognosis, it also has importance for therapeutic choices. So in COPD, if you're someone who doesn't take care of patients with COPD, and until maybe 5 to 7 years ago, if I saw a patient in clinic with COPD, I'd send them to pulmonary. I wouldn't mess with them because I'm an asthma doctor. I'm not a COPD doctor. And now the recognition is that there are a lot of COPD patients in my practice. The place to learn about this is the so-called Global Initiative Chronic Obstructive Lung Disease, or the GOLD initiative. And here's the URL. You can go and download this pocket guide. It can teach you a huge amount, and it's really not difficult reading. It's amazing the great job that's been done on this publication. And the basics in COPD is there are two major components. one in the larger middle to larger airways. There is excess inflammation with resulting fibrosis and excess consistent mucus production that creates this obstruction, so-called chronic bronchitis. In the old days, the classic individual here was someone who had that was oftentimes overweight. They were a little on the cyanotic side. Later in their disease, they puffed a lot, and they were called blue bloaters because they were really big. The other major component is the destruction of the alveolar membrane over time at the terminal bronchioles and into the alveoli themselves, with larger sacs being produced, so-called emphysematous type change, what we call emphysema. And these people very often were sort of underweight, thin people that they were called pink puffers. They had a lot of trouble breathing. So if you're my age, you know what a blue bloater and a pink puffer is. If you're younger, now you've had a little, nostalgia from those of us who have been doing this for a while. So the criteria from the goal being the system for classifying severity, therapy, and prognosis for COPD is assessed by the symptoms such as dyspnea, cough, wheeze, chest pain, the number of exacerbations, the number of hospitalizations, I'll show you in a moment, becomes very important in these, and the PFTs. The major one that is used in the diagnosis of COPD is the FEV1-FE ratio of less than 0.7 after bronchodilator. And then the FEV1 is used to classify them in terms of severity. There are various stages, the so-called gold stages, 1 to 4, in the established COPD patient with post-bronchodilator ratio less than 0.7. They are classified 1 to 4 as mild, moderate, severe, and very severe. And they use the FEV1 greater than 80%, 50 to 80%, 30 to 50%, and less than 30% in very severe. And you can imagine these are the people that don't breathe very well. And it's a very real problem for them because they can, not unlike in asthma, where we can go to a major life-threatening exacerbation from someone with mild disease, these people can move through these stages if there's an appropriate insult that occurs. They continue to smoke heavily, they're exposed to certain toxic chemicals, they get an upper respiratory infection, particularly a viral infection, etc. This is a little thing, and I know people sometimes don't like to see all this, and let me just walk you through a couple of these, and then if you're interested in studying it in more detail, here's the reference down here at the bottom, and you can come back and look at these slides later on. But when there's insults that occur to the airway, and the number one thing in COPD is cigarette smoke and pollution, but it's not the only thing. This can be, there are people who've never smoked a cigarette in their life, who've unfortunately lived around other smokers, secondary smoke, or who've never lived around cigarette smoke to any degree, but they've lived in polluted environments, urban environments, or their occupation, or they've had recurrent viruses, or they've got underlying phagocytic disorders that allows recurrent bacterial infections. The commonality here is the damage of the airway epithelium. There's several pathways that can go. The macrophages, which are scavenger cells that come from blood monocytes, move into the airways or into the adventitial areas underneath the airways, the lamina propria areas. They move into this area and they become activated by various chemokines and adaptive and innate immune mechanisms, but the ultimate effect is the recruitment of these neutrophils. Neutrophils are very, very potent host defense cells that are full of things that are used to kill off bacteria and other pathogens. Unfortunately, if they accumulate and then they themselves begin to degranulate, the same enzymes used to be protective can be very damaging. And if they're in the area of the alveola and alveolar walls, the destruction of that can result in this emphysematous change that we're talking about. The other part of this on the other side, if you look with me on the other side, with the reactive oxygen species that occur from some of these things, pollution, cigarette smoke, and there's a reprogramming of these basal epithelial cells, and they shift from being epithelial cells, which are characteristically, they bind together, they adhere one to another, they provide barriers, if you will. Endothelium which is endothelium is for blood vessels and lymphatics. Epithelium is usually cover other surfaces, the lung, in this case being the major one that we're talking about. There's a so-called epithelial to mesenchymal transition. There's 3 types of these EMT cells. The EMT3 cell is associated with pre-malignant changes. So some of this, smokers, this is one of the presumed mechanisms where smokers can be susceptible to lung cancer, but others is the EMT1 cell is one that is producing factors that are going to activate fibroblasts to become lay down fibrin and scar, if you will, the lung tissue, the lung airway, related to then a permanent decrease in airway patency. Along with this, in the middle part of this is that now there are multiple cytokines, 3 of which are commonly referred to: interleukins 25, 33, and thymic stromal lymphopoietin, or TSLP. And there's a commercial, and we'll talk about this one in just a second. There's a commercial monoclonal antibody that's used in asthma against TSLP. These are called alarmins. So when the epithelium is damaged, they release the alarmins, and there are types of cells that are like CD4 positive T cells, but they're not CD4 cells. They're called innate lymphoid cells. And they have 3 types of them. Type 2 is the one that's going to be producing IL-5. IL-5 is a recruiter, activator, and life prolonger for the eosinophil. And just as the neutrophil has its own levels of toxins, so do the eosinophil have their own toxic granules that are important in host defense, but when they get out of hand in the airway, they can create inflammation and with ultimately remodeling as well. And then the other part is through this cytokine network is goblet cell activation that produces large amount of mucus. So you've got emphysema, lots of mucus, and fibrosis for chronic bronchitis that represents the pathophysiology, the spectrum of this. Well, what about management? First of all is to make sure, just like anything else, there's a differential diagnosis. And for the sake of time, I'm not going to go into all that in terms, I could spend 3 hours talking about this very easily. But the representative symptoms, dyspnea being the most common one. The risk factors are smokers. They work in a polluted environment. They live in a big urban with lots of airway pollution. And then spirometry that shows that they have, with bronchodilators, evidence of a FEV1 FVC ratio of less than 0.7. Then there's an initial assessment, and their gold category is scored. They also have an assessment of their symptoms. I'll show you this in just a second. They now call it the gold ABE system. They get a history of their exacerbation. Are they still smoking? How long did they smoke? How many packs did they smoke? They measure alpha-1 antitrypsin level because there is a certain subgroup of COPD patients that have a deficiency, and if that can be recognized and treated and they'll stop smoking, it can slow down the progress of their COPD significantly. And then other comorbidities, they can have congestive heart failure with it. They can have a history of tuberculosis or other lung infections. They can have diabetes. They can have other complicating things that will make treating them effectively more challenging. The initial management, smoking cessation, always pressed. It's important to counsel and not to preach. My experience, not as a smoker, but as a healthcare provider who's talked to many, many people about smoking over the years, people respond to suggestions and affirmations more than they do to condescension and mandates. Vaccine status is very important for these individuals. Their pneumovaxes, their flu vaccines, now COVID vaccines, that they keep up to date in these, because their respiratory infections that for you and me might create a cough or make us feel bad for a week can be a mortality statistic for them. Active lifestyle and exercise. These people very quickly become physically deconditioned because it's difficult to breathe. So they just sit around. When they sit around, the body starts to take havoc on that in a very short period of time. Initial pharmacotherapy we'll talk about in a moment, and then self-management education. Shared decision-making is very important in COPD to help these individuals to manage their risk factors, to make sure they have good inhaler techniques. Just like in asthma management, Back in the day, there was one inhaler, and they put different kind of medicines in the inhalers, different colors, but the mechanics was exactly the same. And by being the same, if you taught them for one, you taught them forever. And now virtually every product has its own inhaler, dry powder inhaler, meter dose inhaler, etc. And each one of them takes their technique, and each one of them takes reinforcement of the technique, helping people understand breathlessness, dyspnea, the perception of dyspnea. There are in COPD, just like there is in asthma, there are over-perceivers and there are under-perceivers. And it's important for us to help them to relate their perception of their breathing to the more objective measures that we have of where they are with their airway. Written action plan for COPD, though it's probably longer than it is for asthma, is still extremely important for these individuals. And then managing the comorbidities. If the person caring for their COPD is not going to manage this, then she or he needs to make sure that the patient has someone who will manage it. So if it's diabetes or heart disease or history of tuberculosis, etc. A constant, consistent review here over and over again, every time these individuals are seen, is very important. Assessing as their disease may progress, when they may need oxygen, some other procedures, palliative approaches, lung volume reduction, etc. Updating their vaccine status, which seems to fall behind very much in these patients oftentimes, and then adjust both their pharmacotherapy and non-pharmacotherapy based upon this. This is the overall management principles for caring for these patients. This is this ABE assessment tool. It's based upon the spirometric confirmed diagnosis, again, as we talked about, post bronchodilator ratio less than 0.7, assessment of their obstruction, which is the gold classification, and then assessment of their symptoms and risks of exacerbation. In the older version of gold, they would have an A, B, C, and D, and now they moved this to an A, B, and E. There are two questionnaires that are used, the MMRC, which is a one questionnaire that has it's a 0 to 4 score based upon an assessment of dyspnea, and a CAT score, which is 10 questions with a 1 to 4 for each one of them, so a maximum score of 40. A different pulmonologist and COPD people put different rate on this, but these are tools that are commonly used, and in this assessment, they're both done. And there's no real reason not to, as we are doing, if you're going to do the CAT, which is a very useful tool, the MMRC is the same. It's one more question, so it's worth doing. So the exacerbation history per year, if there's more than 2 moderate exacerbations, typically requiring courses of systemic corticosteroids, or one that leads to hospitalization, then they're put into the E category, regardless of what their symptom category is. But if they have lower numbers of exacerbations, then their symptom categories help classify them as A or B, and it has to do with both prognosis and approach to therapy. Now, what do you do in group A, B, and E? If you start with group A, they're in good shape, low number of exacerbations or none, and low numbers on their symptom scores. You just give them a bronchodilator. They can have a long-acting bronchodilator, or they can have an antimuscarinic, but you give them a bronchodilator. You add a combination if the number goes up to B, and then if the number goes up to E, you consider adding an inhaled corticosteroid if their blood eosinophil count is greater than or equal to 300. And remember, in almost all of our clinical labs, 300 is still in the normal range. But the idea is that if their eosinophil count is going up, then they're more likely to be responsible to inhaled corticosteroids. And indeed, this can give you an idea of factors to consider when adding inhaled corticosteroids to the long-acting, if they are history of hospitalizations or exacerbations, i.e. they're in category E, or they have moderate exacerbations, again, category E, or blood eosinophil counts greater than 300, or a history of or current asthma, then it strongly favors adding inhaled corticosteroid. Let me back up one step. There may be some of the listeners that are not aware of, well, what's the big deal? Why wouldn't you use it? For the longest time, they did not, the pulmonologists in particular did not want to use inhaled corticosteroids for COPD management, because there was the literature that strongly suggested it increased their risk for life-threatening pneumonia. The more recent data have compartmentalized that a little bit better and it's not as a global anathema as it used to be. And so those that have long-term taken care of COPD patients and those of us that are more recent to caring for them are not nearly as adverse to using inhaled corticosteroids as they were in the past. The favored use is if they have one moderate exacerbation or blood eosinophil count 100 to 300, so a B, but it is appropriately not to use inhaled corticosteroids if they've had repeated events of pneumonia, regardless of the infectious etiology, if they have low blood eosinophil count, or if they have a history of mycobacterial infection. What about using the blood eosinophil count for therapeutic decisions? And if you have individual who starts out with LABA or LAMA and they continue to have exacerbations, if the eosinophil count is greater than 100, then adding inhaled corticosteroids is appropriate. If the exacerbations continue and the eosinophil count is less than 300, maybe switching to a LAMA with the LABA becomes appropriate. If the eosinophil count goes up again, then triple therapy, and there are commercial inhalers that have all three in it: inhaled corticosteroid, a LABA, and a LAMA. If the exacerbations still continue, then using PDE antagonist and or antimicrobials become an important thing to do. And in this case is roflumilast and roflumilast, I can't say it right, sorry, and azithromycin are two examples that they put in this paper. Again, a very nice paper from Peter Barnes from London. This is a paper that would be worth reading if you're interested in this topic. There is a concomitant to the GOLD, the Global Initiative for Asthma called GINA. I think everyone that takes care of asthma patients is familiar with GINA, has been updated earlier this year. And this has to do with the idea of the asthma, the normal patency of the airway with bronchospasm and inflammation as a result of various exacerbating factors that make this worse. The classification, again, was updated in 2023, assessed by airway function, both obstruction and reversibility, as well as hyperresponsiveness, concomitant comorbidities, exacerbation assessments, and their response to therapy. Clarification revisions in 2023 from earlier versions of GINA. Intermittent is eliminated, so there's no more intermittent, mild, moderate, and severe persistent. There are various stages. I'll show you this in a second. And therapeutic recommendations that have been revised based upon the severity. This is endotype. Again, remember, endotype is clinical presentation based upon specific mechanism. There's now 4 major ones associated with asthma. Common triggers: allergens, pollens, dust mite, protein, animal danders, microbes, particularly viruses, and pollutants, all of which have an impact on the epithelium and the normal inflammatory components that are there. You have the eosinophilic asthma that is allergic in nature. This is a classic allergic component, B cell with IgE that are mast cells. The release of the mast cell factors, both through Th2 and the production of prostaglandin D2, increase the eosinophil in terms of recruitment, activity, and perseverance. It anti-apoptosis factors. It stops the early programmed cell death of eosinophils, and they hang around longer. And an eosinophil in tissue is not something you want unless it's fighting an active infection, because it will eventually degranulate. And as it degranulates, all those different major basic proteins and other eosinophilic proteins create lots of tissue damage. Lots of eosinophilia, damaged epithelium, thickened reticular basement membrane, airway smooth muscle hypertrophy, as well as hyperactivity, mucus production, but no neutrophils. The eosinophilic non-allergic is essentially the same pathway, except it does not, the activation of the eosinophil and recruitment is not because of an IgE-mediated mechanism. It's primarily because of these alarmins, IL-33 and TSLP, as well as IL-25, but 33 and TSLP being more important, that activate these ILC2 and produce a type 2 environment. The mast cell, the IgE-mediated mast cell, is involved in this as well. There is a mixed granulocytic asthma that includes both eosinophils and neutrophils. That is an overlap, if you will, in asthma of the non-allergic, so-called T2 low or T1 high asthma. And that's where you have, again, the alarmins, IL-23 being involved in this, and you're engaged with innate lymphoid cell type 3 that is very similar to a Th17 cell, having impact on a macrophage that produces a chemokine ligand that recruits neutrophils, producing a primarily neutrophilic thing. High neutrophils, damaged epithelium, lots of mucus produced, not as much thickening in the basement membrane, not as much airway hypertrophy, and no eosinophils. And the one that nobody really knows what to do about, and fortunately it's not all that many, but when it happens, the so-called paucigranulocytic asthma, essentially they don't have neutrophils, they don't have eosinophils, they tend to not have thickened reticular basement membrane, but there's lots of damaged epithelium and there is hypertrophy. These are the ones that have scarred airways with a lot of irreversibility. The endotypes can further be classified on mechanisms, things that you would appreciate: the allergic asthma, as we've discussed, exercise-induced asthma, which is more amenable to treatment with cystinyl leukotriene modifiers, eosinophilic asthma that we described, and we'll talk about the biologics in just a moment. Aspirin-exacerbated respiratory diseases fit into that as well. On the other side, these so-called Th2, they go along with severity, they go along with age of onset, and there is a significant influence in genetic background. And all I can say about that is, while we all appreciate that, and we know that there's family history associated with this, and there are a lot of gene candidates, that has not really been established on the individual patient level yet to direct therapy, but give it time. In the next several years, I strongly believe there will be data published that will give us who care for asthma as well as COPD, as well as overlap, that will give us the ability to modify therapy and therapeutic decisions on the basis of some of the genetic information that we get. In asthma management, the basic idea is to assess, confirming the diagnosis if necessary. I get consults multiple times a year of individuals who've been treated for asthma for years and are just not getting better. And it turns out they're not getting better because they don't have asthma. And there are lots of reasons for that. And for the sake of time, we won't go into that. But symptom control and modifiable risk factors, comorbidities, inhaler techniques, and preferences, both the patient or their parent if they're a child, and the goals that they have. Assessment becomes really important each time. Adjustment of the modifiable risk factors, non-pharmacologic therapies, environmental control, et cetera, the specific asthma medications, and education and skills training, and then reviewing symptoms, exacerbations, side effects, lung function, patient and parent satisfaction. This is what we do in our management principles of taking care of asthma patients. In the major young adult to adult population, the first assessment, again, as we talked about, is all of these. And then there's two pathways that can be taken. A more recent one, many of you may have heard of this, called the SMART therapy. And SMART specifically involves the use of formoterol. There are other therapies being evaluated called MART therapy, and it doesn't use formoterol. It uses other long-acting bronchodilator agents. But this principle is using the argument that the ICS formoterol, and formoterol has its own one because formoterol, as opposed to some of the other LABAs, has a very rapid onset of action. It is up and running within 5 to 15 minutes after the inhaler, which is comparable to that of the short-acting bronchodilators like albuterol. It's using the same controller medication, the two-agent ICS formoterol, as a reliever as well as a controller. And this is in the pathway where if there is concern for the individual regularly using their long-acting bronchodilator ICS combination. And there are data to show it reduces the risk of exacerbations compared to using SABA in this group. You have different symptoms, less than 4 to 5 days a week. Then they're in step 1, 2, as needed low-dose ICS formoterol. Symptoms of most days are waking with asthma 1 or more times a week. They move up to step 3, and that's to use it on a regular everyday basis. And again, remember the reliever is as needed low dose ICS for Moderol. That's typically 1 puff. Daily symptoms are waking with asthma once a week or more, low lung function, they go to step 4. And then if that severity moves up, they go to step 5, where they add on LAMA, or they can refer. And if we're already specialists, we don't refer to ourselves. This is if they're in the primary care range, then getting a specialist, an asthma specialist involved is appropriate, considering high dose maintenance ICS for Moderol with or without biologics. We'll talk more about these in a moment. The more classical one that most of us would be familiar with if we've taken care of asthma for any period of time is here, the so-called track 2. If you've got individuals that are likely to be adherent with daily control therapy, that becomes very important, and the good relationship is to be candid with these individuals. Are they going to use it? Are they not? Now, the challenge that can be here back from track 1 here in the US is reimbursement, because if insurance pays for these combination medicines, which are by definition more expensive, and they calculate that they're using 1 puff twice a day, or they're using 2 puffs twice a day, whatever it is, they calculate what the monthly use of this is. And you've got someone who's also using it as a reliever, particularly if they're using it a lot, then that can be a problem. And that has to be considered something you have to look at. In this pathway, it's not, because they're using their short-acting bronchodilator, and the symptoms are less than twice a month. They use ICS whenever the SABA is taken. So they use their albuterol inhaler, and they use whatever ICS that you have suggested. There's one recently on the market. There are others under evaluation that are SABA ICS combination medicines that have been released here in the United States. And there's a thought that this might well take that place, that it'll already be there when they're using their SABA. They'll get their ICS automatically, because it'll be 2 products instead of 1. Symptoms twice a month or more, but less than 4 or 5 days a week, they step up accordingly, and then they add on the biologics when it's appropriate. So it's a similar stepwise pattern. The difference is the reliever is a short-acting beta agonist versus a long-acting, and when the combinations come on. The combination actually starts here in step 3, as opposed to here in step 1 and 2. For kids, this is younger kids, again, confirming the diagnosis, looking for comorbidities. The symptoms here, twice a month, low dose ICS, step 1. They don't have that combination here for the kids in that age category. And they move up the stepwise here until they potentially have the use of biologicals in the 6 to 11 category, depending on the specific biological. When we say biologics for obstructive lung disease, currently in the US, it's just for asthma. I think you'll see it coming for certain subgroups of COPD. When they say biologicals, they're typically referring to monoclonal antibodies directed against specific components of the inflammatory chain. IgE is the first one. It's been around for a long time. Omalizumab's been around. It's useful in asthma, proven track record. And then the argument is whether you use this only in people that are elevated IgE versus not, people that are allergic versus not. The debate rages, and it just sort of depends on where you are as to what you think about that answer. IL-5, we've already talked about the importance of IL-5 in the role here, eosinophilic chemotactin, growth factor, anti-apoptotic, approved drugs. There's 3, benralizumab, mepolizumab, and reslizumab. IL-4, this says 3, that's a mistake. That should be 13. We'll correct that before this is posted to the web. Mast cell growth factor, promote mucus formation, switch to IgE. Both 4 and 13 could switch to IgE. 13 is particularly important in mucus formation, and 4 is a mast cell growth factor. And the approved drug for this is dupilumab. It's an IL-4 receptor alpha, which is shared by both the IL-4 and IL-13 receptors. And then the newest one on the block, thymic stromal lymphopoietin, TSLP. It's one of the 3 alarmins that we've already showed you. It was supposed to be a drug that it didn't matter what your eosinophil count was, it would work. And indeed, in the eosinophil poor category, this is the one that seems to work better than the others. but it still works better in the more eosinophilic asthma thing. So this one is really active and works well in eosinophil rich, but it also works better than some of these other choices in eosinophil poor asthma. What about the overlap? Defining it, asthma is a heterogeneous syndrome usually characterized with varying degrees of chronic airway inflammation, defined by medical history and presentation that varies over time and intensity with various airflow obstruction. That's straight from the GINA guidelines. COPD is heterogeneous, characterized by chronic respiratory symptoms due to airway abnormalities and or alveoli that produce frequent, often progressive airflow obstruction. That's straight from the GOLD criteria. And then the overlap is collectively described patients who have persistent airflow limitations along with clinical features consistent with both asthma and COPD. The important thing is that we tried to call this a syndrome. We called it ACOS, asthma COPD overlap syndrome. And this is not a single disease entity, though there is controversy amongst experts now with the different British and Dutch interpretations. One says that it is a distinct entity, the other says it's concomitant illnesses. And other than the argument, what is the value of trying to decide what this is one way or another? And I'm going to set this aside for a moment. If somebody has a question about it, I'm happy to address it. But I'm going to say for the moment, for the sake of discussion, it doesn't matter. It doesn't matter if it's a single entity. It doesn't matter if it's concomitant disease, because the patient is in that category. And what are we going to do for her or him? That's what really matters. Why is it so important getting the right diagnosis, treatment that affects disease control, risk of exacerbation of quality of life, and a mortality risk? Asthma is considered low, COPD is considered high, but in asthma COPD overlap, the mortality risk is higher than asthma, but less than COPD. And here's the study that was published a couple of years ago. Large numbers of patients, almost 400,000 patients, 65,000 of whom had asthma, 325,000 of whom did not have asthma. COPD patients, 45,000 that had COPD, 230,000 that did not, and an overlap group that there was 22,000 of them. When they compared the mortality risk for overlap versus asthma, it was a little bit higher, about 9% higher, and that was statistically significant in this for a hazard ratio for mortality. But when they compared overlap with COPD, it was about 11% lower. So you can say that that overlap is somewhere in terms of mortality risk in between that of asthma and COPD. The pathophysiology of overlap, the asthma components with the eosinophil and mast cell activity, remodeling Th2 inflammation. Asthma patients smoke and they have pollution exposure and biomass fuel exposure. And then the other side of this, COPD, neutrophil, CD8, cytotoxic T cells, macrophages. People with COPD have allergies, and there is a certain amount of remodeling that goes on. So there's a cross in this. The genetic susceptibility we've already talked about, and there is a suggestion that early childhood lung disorder might play a role in this overlap as well. And then this epithelial to mesenchymal transition that we mentioned may be actually prominent in ACO, at least in some of these patients. And the question is we raised as a unique disease. So the approach to therapy of this is likely to be asthma, features of both, likely to be COPD. Look at the history. Symptoms over time, are they more like asthma? And you treat them like asthma. What about their lung function? Do they have variable airflow limitations, or do they have mild persistent airflow? So they've got maybe their ratio is 0.68, but the ratio is not going to be 0.4 and call it asthma. It's just not going to be that way, okay? The other side of this that you would treat as COPD as the dyspnea persistent on most days, later onset in life, more related to history of smoking. But remember, asthma patients smoke, and there are some COPD patients that never smoke. And then lung function, persistent expiratory limitations. The features of both treating as asthma is the intermittent middle of the road function. The pharmacology treatment, here's the red that is I want to emphasize in this, and that is you don't give LABA or LAMA without ICS to an asthma patient. You do not manage them with simple bronchodilators if they are at stage 2 or above. Maintenance oral corticosteroids only as a last resort, or you reserve that for when they are failures. You don't put them on tin of prednisone and forget about them. On the other hand, treating a COPD using the GOLD report, LABA, adding the ICS as we've discussed, avoiding high-dose ICS or maintenance oral corticosteroids unless absolutely necessary much later in disease, and relievers containing ICS is not recommended with the exceptions that we discussed before. The middle of the road, the big red one, is not giving LAMA or LABA without ICS, again, even with the mixed features of both, and maintenance oral corticosteroids is only as a last resort. And then, of course, is regular follow-up and reevaluation with these folks. The measurements here, the FEV1 pre and post is comparable, is not consistent with COPD, reduced required for the diagnosis of COPD and the overlap. The bronchodilator greater than 80% is more consistent with asthma, less than 80% post-bronchodilator is more consistent, or is necessary, I won't say more consistent, but is necessary in COPD and overlap. And the improvement of FEV1 of the 12% in 200 mil is more consistent with asthma, and very much more consistent with asthma if you move up to 400 mils. Some people do 200, some people do 400. And then the lung function test, DLCO, is normal in asthma, oftentimes reduced in COPD. The blood gases are normal in asthma, can be abnormal in COPD. Airway responsible is not really very useful. Imaging can be useful, but less so in COPD less so in asthma than COPD. Atopy will increase in asthma, but it is not really, doesn't rule out COPD if they have atopy, because COPDers can have allergies. The FeNO is usually normal in COPD unless they're current smokers, and can be useful for inflammatory versus less inflammatory. And blood eosinophil is higher, but it can also be here. This is much more blurred than it used to be. And then the inflammatory cell analysis is really not done in large populations anymore. So the final slide in summary is that asthma and COPD are both obstructive lung diseases. It's a growing problem in our world. It's been estimated that COPD will be the third leading cause of death globally by 2030. This is not something to be taken lightly. Asthma and COPD represent a spectrum of obstructive lung disease. Both are inflammatory disorders with an overlap in diagnosis, classification, treatment, and outcomes in many more patients than we might realize. And more precise diagnosis and treatment is important to effectively treat patients and ultimately develop mitigation and prevention strategies. With that, I thank you for your attention, and I'll turn it back over to Andrea to moderate the questions.
Thank you, Dr. Marshall. I know there was a lot of detailed information. And for those of you that are treating patients with asthma, remember that we are recording this webinar. You can go on our website within a day or two and re-listen if there's parts you missed or wanted to review. So thank you, thank you. I was taking notes furiously as you were going along. So our first question is, are there any similarities between a viral respiratory distress and either a COPD or asthma exacerbation?
Sure. This is particularly relevant in little kids. It's particularly relevant in the little kids in infants in the first year of life, because they, by definition, have smaller airways. And viral bronchitis and even a bronchiolitis in infants, small children, can move up into adults, can create a turbulent airflow. And remember, wheezing is nothing more than turbulent airflow. It's a sound that results from that. And back in the old days, they would talk about asthmatic bronchitis. And that term has been dropped, is not really used by many people anymore, because the term asthma implies a persistence or a permanence to it. But you can certainly, with a viral bronchitis, have an asthma-like picture. And some individuals, even adults, need airway steroids to help reduce the inflammation that reduces the duration of their symptoms substantially, sometimes as much as 50%. The issue is that if they get further 8 to 12 weeks after the acute episode and you were to assess them with a bronchodilator or assessment or assess them even with a methacholine, they would be negative if they don't have asthma or they don't have underlying COPD. So acutely, it can mimic it, but on a chronic basis, it does not.
Okay, thank you. Someone says, what is your opinion of the recent recommendation of the zoster vaccine for patients with COPD?
I'm a huge believer in it. The COPD patient is almost by definition immune compromised. And I've shown you some of the cellular and the tissue-based level. We've limited ourselves to the lung in this discussion, but systemically they are both in the nature of the chronicity of the disease. Chronic disease produces stress, and as you heard in the introduction, I study stress and how it impacts immunity. But it's not only psychological stress, because it can't breathe very well, it's physiological stress as well, plus the therapies. These patients, COPD patients, as their disease progresses, they see more and more and more steroids. Never let anyone tell you that higher dose inhaled corticosteroids don't have systemic immune effects. They do. They don't have the same systemic immune effects as the equivalent systemic administration, but they're there. And if they're using them over a period of time, yes, their immune system is going to be compromised. So good vaccines, including zoster vaccines, should absolutely be recommended to all these patients.
Wonderful, thank you. Our next question is a little bit long, so hold on to your seats here for this one. Why not follow what the field of psychiatry has done with the creation of autism spectrum, move away from asthma, ACOS, and COPD towards reactive airway disorder, putting greater focus on treating the individual patient, not the label, thus more patients can be evaluated for the underlying disease?
Oh, I mean, I love that idea. And I truly believe that we're working toward that idea. The problem is that old thoughts die hard, old traditions die hard, and they tried unsuccessfully to try to do this with ACOS, where they were going to develop a disorder that was like the autism spectrum disorder. The problem is that for autism spectrum disorder, from the work that they've done, and I'm aware of the fact that there's even some controversy there, there's a therapy based upon the disorder and the individual therapy for patients. That's the whole principle of precision medicine. And I think that's a goal that they have for this. And I love the idea of discarding the term asthma and COPD and calling it an asthma or an airway obstruction spectrum or something like that, something like that. I just think that we're just not there yet. But I love the idea, and I would be very supportive of it as the data would support.
Thank you. Yes, as you say, the field is always changing, including the terms. So I'm going to combine two questions here. We have a lot, and I'm, cognizant of your time. What does a spirometry look like for asthma COPD overlap? And can you tell if a patient has COPD component without using spirometry?
That's a wonderful question. And that is actually a question at the basis of which the concept of the ACOS concept fell apart, because it depends. And in fact, what they were trying to do is that if the spirometry was more like asthma, i.e. had a higher level of reversibility, or there was a higher blood eosinophil count, you treat them like asthma. If they're more neutrophilic and there's more obstruction and it's more permanent, you treat them like COPD. The problem is, of course, is that, again, as I showed in that last slide of the mechanism of the overlap, there is, again, that spectrum there, finding where that patient is in the spectrum. And when you have a mixed pattern, so you've got someone that's got a allergic component to it, but their sputum is largely neutrophilic. How do you treat that person? Much of what we do now is still empirical. We look at guidelines, we look at trying to classify them, and the gold is doing this pretty well in COPD, and Gina has done it very well in asthma, but there's not been a limit of those two groups getting together and say, let's do a similar one for overlap yet. And the reason that there's not is there's simply not enough data from studies to defend what they would do in that unique things. And I say in that these are ones that are good to teach us, that they call medicine of practice for a very good reason. We try with each individual patient to discern what is most likely to respond. Is it their COPD effort? Is it their asthma effort? treat them, monitor them carefully, and then be willing to adjust accordingly.
Thank you. Someone else is asking about peak inspiratory force when using dry powder inhalers, which I know can be an issue with certain people. So is this a concern for asthma and ACO or just COPD?
No, I think it's a concern for anyone, and that becomes part of the assessment because we now have tools. There are commercially available tools to allow the individual, and they're not terribly expensive, really. They're not. There's several $100s, and they can be used in the office of people that take care of folks with obstructive airway disease that not only assesses their inhaler technique, and it assesses their ability to do inhalation, whether it's for the coordination necessary for a meter dose inhaler, or whether it's the inspiratory effort necessary for a dry powder inhaler. So what I would argue is that if you take care of a number of patients with obstructive airway disease, that's something you should have in your armamentarium because it's useful. It's designed not only for you to know, it's designed for them to know because they got green lights when they're doing it well, they got red lights when it's not working as well. And it allows them to see firsthand the technique that you're teaching them, that it works or it doesn't work. So that's what I would recommend.
I love that instant feedback that patients will get, because oftentimes when I coordinated an asthma home visit program, people say, oh, honey, I know how to use my inhaler. I've been using it for a long time. I could probably teach you a thing or two.
Right.
And then you'd watch
Absolutely.
their inhaler technique and think, oh, yeah, you haven't been doing it right this whole time. So I love having them see that, having them see the green and the colors to know for themselves, oh, I thought I was doing it right this whole time and I'm not. So that instant feedback is brilliant.
Absolutely.
Thank you for that. Yes. We only have time for a couple more. I know that everyone's busy and I know that you need to get back to work. So this is a question about peak flow and if people should use that. And I think that oftentimes depends on the provider, peak flows and spacers. So there can be some controversy on that, but what is your opinion about having them do peak flow meters?
Well, peak flow and spacers are like politics and religion. There are a lot of people with different opinions. There's not as much objective evidence as you would like to have. I grew up in the age where all asthma inhalers, particularly the controllers, you always used a spacer. It decreased side effects. It improved inhalation delivery, yada, yada, yada. Everybody was a big believer in it, and peak flow meters were what you used. And we had paradigms that were based upon peak flow meters. Those have sort of fallen out of grace because the peak flow tends to be a measurement of larger airway, and asthma in particular is more of a measure for middle and smaller airways, more of a disease of middle and smaller airways. I'm not aware, again, my caring for COPD patients is relatively recent for me compared to asthma patients, but I'm not aware that the COPDers are using peak flow meters to any high degree. I think that the spacer technique, I still have some patients that use spacers, obviously not for DPIs. It's not going to work, but can work for MDIs. I think the effectiveness of it changed a lot when they moved from CFCs, the chlorofluorocarbons, to the HFAs back, 20 something years ago, because the delivery is so much different, the particle size is different and so on. But having said that, I still have a few people that have real problems with coordination, and either because of insurance reasons or because of the specific combination therapy that I've got, they do better with a MDI than they do with a DPI, and they do better with a spacer than they do without one. So it becomes very individualized, and I think that it's going to be hard to get a consensus anytime soon, because there's studies that need to be done that nobody's ever going to fund to do.
Yes, because we're all short on time and funding, correct?
Correct.
Yeah, I understand. So apologies for all of you that we aren't able to get to all the questions, but I want to be respectful of everyone's time. Dr. Marshall, if you can just go forward just one more slide. So this is, if you have any other ideas for webinars or you want any other feedback, jot them down in our evaluation survey. I look at every single comment in there. Also, another thing is oftentimes people will ask for topics, and we've already done a webinar on that. So please check our website at allergyasthmanetwork.org scroll down to the bottom and you can see a lot of the recorded webinars. So thank you again for joining us. This is Andrea Jensen for the staff of Allergy and Asthma Network. Join us as we work every day to breathe better together. Thank you, everyone. And thank you, Dr. Marshall.
My pleasure.